Chapter 32, The Dimension of the Mind, Te Taha Hinenaro. In contemporary psychiatry, medications are the foundation of treatment of mental illnesses, replacing such coarse and brutal methods as the frontal lobotomy and the insulin coma as treatments of choice. Patients today have only escaped this barbarism by virtue of being hospitalised some 50 years on from the heyday of these practices. Electroconvulsive therapy is still in use in New Zealand, mainly in the treatment of entrenched depressions, but today its use is subject to strict codes of practice. Psychiatry is a profession that has seen some very dark days indeed. As a student, I worked in a residential home for people with intellectual disabilities. One of the women there was in her early 50s and she had been given a frontal lobotomy in her teenage years. Her parents had sought psychiatric help for her because she was difficult. Well, she's not anymore. And operating on the seat of her emotions, it was like they had taken her soul. She was left with a blank face, an unanimated voice, and the mental capacity to concentrate only on mindless, repetitive actions, cutting pictures out of magazines all day, every day. I sometimes wondered what her parents thought of the result. So in our enlightened era, we have replaced the sharp surgical instrument with the judicious use of often blunt psychiatric medications as the main weapon against insanity, perceived or actual. Every person diagnosed by a psychiatrist has their own experiences with the use or not of medication. I shall concentrate primarily on my own. I become addicted to drugs, so the whole issue of pharmaceutical medications was bound to be a tricky one. How could I safely take the medications prescribed, some of them easily addictive in themselves, without returning to active addiction? This was going to be critical if I ever hoped to lead any kind of sane and stable life. In recent years, a new term has found its way into the lexicon of psychiatry, that of dual diagnosis. This description wasn't in common usage when I was in hospital, but it is now recognised as a disorder in itself. The label of dual diagnosis is applied to people suffering from an addiction to drugs and or alcohol and from a diagnosable mental illness such as schizophrenia or bipolar. The use of this term is an overdue acknowledgement that there will be some complicated issues in treating the sufferer with conventional psychiatric methods. My own experience has borne this out to be true. My misadventures with Prozac showed me that whilst cannabis had always been my drug of choice, I could easily cross-addict from one drug to another. I wasn't fussy, and most of us aren't. I was going to have to apply what I knew about my cannabis addiction to this whole new pharmacopoeia of medicines that had opened up before me. On that second admission to hospital as a committed patient, I was hit hard. In an effort to bring me down from the high of the mania, the psychiatrist threw everything at me. I was started on lithium, 2 antipsychotics, being Mellaril, which is thiazidine, and chlorpromazine. Temazepam, which is a benzodiazepine sleeping medication, clonazepam, a benzodiazepine anxiolytic and anti-anxiety medication, and cogentin or benztropine, which is a pill to mitigate the side effects of all the other pills. This was the beginning of a long relationship between me and the mood stabiliser lithium. Lithium has been the mainstay of treatment for bipolar disorder since an enterprising Australian psychiatrist discovered in 1948 its pacifying effects on guinea pigs and, legend has it, lobbied, albeit unsuccessfully, to have it put into the nation's water supply. Lithium is a mineral salt. No one is exactly clear why it has the ability to regulate the extreme swings in mood disorders, but it does so successfully to some extent and its use continues. Lithium is hard on the body. The user should ensure they have a blood test every 3 months to make sure it's within the therapeutic range and not accumulating to toxic levels in the blood. It has a fairly narrow therapeutic window. This means basically that, whilst levels vary depending on the individual, Too little will have no effect, and too much will eventually induce organ failure and put you in a coma. Lithium's most obvious side effects are notoriously well known and documented, so it's not difficult to find information. I noticed the immediate onset of a hand tremor. Alongside this was the emergence of a great thirst. The side effects of medications vary depending on the individual, but for me the thirst was overwhelming. It was unquenchable. I was totally dependent on the water bottle that I carried everywhere. I would panic if I went out and realised I'd left it at home. I just had to have water. Without it, I would become restless, irritable, and unable to concentrate, and my body would quickly move into the pain of dehydration. The reason for this thirst is that as lithium is a salt, it behaves as a salt at the cellular level of our biochemistry, interfering in the movement of sodium and water in and out of cellular tissue. The continuous fluid intake and excretion puts a big strain on the kidneys, and people on lithium should have their kidney function tested routinely a couple of times a year. Both the lithium levels in the blood and the kidney function can change quite rapidly, particularly in the presence of other illnesses. For example, a bout of vomiting and diarrhea, such as strikes with the gastrointestinal norovirus, can easily dehydrate the body and therefore elevate the lithium level, potentially creating toxicity as the diluting fluid leaves the body. I had my own experience with lithium toxicity. After 14 years of taking the drug, it came to light after abdominal surgery, having been advised to remain nil by mouth for 12 hours prior to the operation. When I awoke from the anaesthetic, I had a thirst like a dying person in a desert. It was insatiable, but I was not supposed to be drinking anything other than little sips of water and sucking ice cubes. But despite the IV saline I just had to drink, I could not control the indescribable cravings. On investigation, it was found that my kidneys had become impaired and my body was no longer excreting the lithium as it should. This explained both the primal pull of the dehydration and why I had been returning some very high blood pressure readings. To arrest any further deterioration of kidney function, on top of recovering from major surgery, I had to begin an immediate managed withdrawal of lithium rapidly over a period of 3 weeks. This is very fast. 3 to 6 months would be a preferable withdrawal period after so long on the drug, and some people choose to take a year to gradually titrate the dosage downwards. The problem with a fast withdrawal is that it can bounce the person back into severe mood swings as the brain struggles to compensate for the chemical changes it detects. Fortunately, the withdrawal went well. I had a GP who was open to allowing me some control in the process. It had taken me years to get to the point where I had earned some autonomy around medication decisions. In partnership, we put together a new regime that we both felt would be kinder to the kidneys without sacrificing too much of the stability the lithium had afforded me. Nervously, we began the downward titration. As the lithium receded from my system, we began to replace it with quetiapine, which is a newer antipsychotic, which also has mood stabilising properties. Under my GP's watchful eye, I gradually increased that dose. I was able to take a small amount extra if I felt a high coming on, and this worked well and gave me a good level of control. However, it wasn't the mania I was so worried about. It was the return of the bipolar depression. No way was I ever going back to that hell. So I also started on a low dose of an antidepressant. I didn't get that right first time and experienced some negative side effects before settling on a newer drug called citalopram, which appears to have a lower side effect profile. On the positive side, lithium had played a significant role in my recovery from mental illness. It has one distinct advantage in treating people with a dual diagnosis. It is not an actively addictive substance. It literally is like taking a teaspoonful of salt a couple of times a day. It does not induce any immediate action that the addict seeks. Its effectiveness builds over time as therapeutic levels in the bloodstream are attained. Lithium stabilised my moods where nothing else would, and neatly sidestepped that part of my addictive personality that was always looking for the next high. I have no doubt that firstly, lithium saved my life, and then it gave me one.